Hey, Gershwin. Hey, listen, we have the Africa show in 30 minutes. Can you come on the panel? You're what? I can't understand you. Okay. All right, I'll call you. I'll talk to you later. All right. Bye. Fucking word. Oh, sorry, boys. Nathalie, Maurizio. Hi, Nathalie. Hey, Maurizio. Let me unmute you both here. How you doing, Maurizio?
Ciao, John. Can you hear me?
Yes, I can hear you.
Okay. I was waiting. I supposed to be out of
Ciao, John.
out of web.
Okay, I have another.
I was waiting.
Let me see if I have another screen open.
Ciao, John.
Out of web.
Yeah, let me see. Yeah, I have another screen open. Hold on. Let me see if I have another screen open. I can hear two voices. Yeah, let me see. Yeah, I have another. Okay. No. Okay, just one. Okay, I just have one on.
Okay.
So hi, Nathalie.
Hi, John. Hi, Dr. Maurizio.
Maurizio, I don't know if you met him before. He was here a while ago.
Yeah.
The neurosurgeon from
No, I've not met
Italy.
him before. Oh, okay, like Dr. Marco.
No, it's from Marco's country. We also have
Okay.
another Italian neurosurgeon, Marco Maloney. He's a spine surgeon from. I don't know if you know Marco. He's from Como.
Milano.
Como.
Como.
Yeah.
Oh, yeah.
He may come today.
Ah, okay.
Okay.
Great.
So we don't start for about 25 minutes. Okay.
Okay.
So you can check your email or whatever. I'm gonna do some things. Okay.
Okay. We too.
I'll be back.
I'll be back.
Okay, welcome everybody. Hey, Marco.
Hey guys, how are you?
Hey, Marco, we have another Italian neurosurgeon here today.
Yeah,
Maurizio. I want you to meet Marco Maloney.
oh, nice to meet you, doctor.
Ciao.
Ciao, salve.
Yeah, he's in Como, and you're where are you, Maurizio? What part of
Ancona.
Ancona, wow.
Ancona.
Marche.
Marche. Adriatic Sea.
Oh, I see. Yeah, I'm from Gravedona, northern part of Como Lake.
Yes. Yeah.
Well, Ulrich, we got the right day.
Yes.
Well, you know, I thought I got confused. I thought it was yesterday, and I put on a Facebook 1 hour. It starts, and then Ulrich wrote
Yeah, I
me,
understand.
Ulrich
Yeah.
wrote me and says, "John, it's the wrong day."
Hello, Dr. Meloni.
Hi.
Hello, Dr. Fortuné.
Hello.
Fortune Ganpi, how you doing? Welcome. I don't think I met you. We've met you.
I'm in Morocco. I'm from Benin, but I'm a resident in CHA Center of Fez in Morocco.
Oh, excellent, excellent. Dr. Bankau, do you know Dr. Bankau from Morocco, a neurosurgeon?
Yeah,
He
of
works
course.
with him.
Oh, okay. Oh, you work
Nice
with
to
him.
meet
Oh,
you.
great, great, super, super.
Thank you.
So that's good. It's good to have everyone here. We're having the app remade. I think I have a developer that knows a little bit more. So hopefully that will be ready in the next week or two. Because with anything like that, I'm learning there's problems, bugs, lots of bugs, but it's still classified as beta stage. So hopefully we'll have it ready within a week or two. We want to make it really easy to access videos like we're making right now. Like right now, this video will be in the front page of the app, which is great. So that means that everyone can just tap it and boom, they see it. And they'll be able to tap twice and enter into the discussion, which leads to a lot of potential good situations. If you're at a cafe and you see someone presenting, you go, "Oh, I think I want to enter into that." Boom, there you go. You go right in. With the, I don't know, maybe smartphones will get bigger. Like my iPad's a good size, I think, to participate in these conferences if you're on the go, on the run.
Mm-hmm.
But you know, people will use what's ever comfortable. So, okay, well, we have a few minutes. So how are things at Harvard?
Well, great. We have a lot of projects going on, a lot of research. So I'm busy. I don't have much to complain about. I'm fortunate that this year it's not yet cold at this time. It's well, temperatures are low, but not as low as they should be.
Yeah.
So I'm guessing things will get really really the weather will be bad probably around December and January, going all the way to February.
Well, if you don't, it's not a good place to be if you don't like cold weather.
Yeah. I mean,
But it's not that. No, it's not that bad. Actually, in New England, it really doesn't get. I mean, real cold usually until February and March later. But it never. New England weather, as you'll see, is very unpredictable. Sometimes it'll be cold early and cold late. It's really you can't really say for certainty what's going to happen. You can dress for it. It's not a huge problem. In Miami, it's more of a heat problem. In the August, wow, it gets. I don't know if it's like that in Cameroon, but it gets really hot, really hot. I mean, sweating hot. You walk to your car and you sweat. You know, like a block, less than like a couple of blocks, or less than a block.
Scorching hot. We We have the same issues.
You have the same mugginess, like it's really a wet, hot, where you sweat a lot.
It is.
But anyways, yeah, we're televising a conference on November 11th from Nairobi, I believe.
Oh, great.
Yeah, it'll be a 2-day conference. I think the 9th and the 10th, I believe. Dr. Jumo, I don't know if you remember his lecture, Jumo Magogo. He was a neurosurgeon from Tanzania. He was in India, but he's back now in Tanzania. No, I'm sorry. The conference is in Tanzania. Let me get it right now. Let me open it up right now and show you guys.
I think I've seen the posters.
You saw the program?
I think I saw the poster online. There's there's a group in Tanzania that works on
spine and brain trauma. Well, actually, it's okay. Let me. I'll share the screen here. Oh, I may have shown you already, huh? Let me see. There we go. Yeah, I think I showed you that a couple of weeks ago, right? Spine and brain trauma in Tanzania. So there's a couple of days. There's a couple of days of live surgery. I think the first 2 days are didactic presentations, and the other days are live surgery, which we can also televise that too if they want. So
it seems very interesting. So
yeah. I'm glad Jumo let us know. We just got to arrange the transmission, but apparently it's a new conference center. I think I get the impression it's a new conference center, so they should have the internet. You know, and I think when they build auditoriums now, you gotta think of internet. I mean, it's just part of the equipment now. You know, if you built it 20 years ago, you wouldn't do it, but now. So Natalie, are you there, Natalie? Oh, she may have stepped away. That's okay.
I think she is. I think she's around because she sent a message.
Okay. Hello, Natalie. I'm trying to unmute you. Maybe she's having trouble too.
Hello.
Oh, there you go. There you go.
Hello, everyone.
Okay, almost ready. You ready to begin, Natalie?
Yeah, of course.
Okay, 2 presentations, right?
Yeah.
Yeah.
So
Not you, but Gawin is doing one.
Darwin.
Gawin, okay. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach, the offices of Neurosurgical TV. Today we have the pleasure of hosting another Association of Future African Neurosurgeons. Today we have Natalie presenting initially, but first let's Natalie Gomsi. She's a general practitioner from Cameroon. But first, let's meet the panelists. Okay, hello, Marco. Welcome.
Hello, guys. My name is Marco Meloni. I'm a consultant neurosurgeon in Gravedona, northern part of Italy.
A frequent participant. And another Italian neurosurgeon, Maurizio. Hi, Maurizio. Could you please introduce yourself?
Yes, I'm Maurizio Iavangeli. I'm a neurosurgeon in Ancona, Italy, Adriatic.
Okay, welcome.
Polytechnic University of Marche.
Okay, welcome, Maurizio.
Thanks.
Hello, Fortune. How you doing? Can you please introduce yourself? Let me unmute you here, Fortune. Okay, unmute. Sometimes I have a hard time unmuting someone. Oh, go ahead, Fortune.
Yes, I just want to join you on my computer because right now I'm on my smartphone, so it's not easy on smartphone.
Okay, what's your name and where you're from and what you're doing? What, a student?
Okay, I'm Fortune Gankwe. I'm from Benin, but I live in Morocco. I'm a neurosurgery resident at Assantou University Hospital of Fez. It's in north of Morocco.
And a friend of Nauru. That's great. Welcome. Hello,
Thank you.
Ulrich. How you doing?
Hi, everyone. I'm Ulrich Sidney. I'm a research associate at a program in global surgery at Harvard Medical School, and I'm equally the founder and president of the Association of Future African Neurosurgeons. Nice to meet you all.
Very good. Welcome. Nagu, Emmanuel, could you please introduce yourself? Can you hear me okay? Perhaps not. Okay, Nathalie, welcome, and it's all yours.
Okay, thank you, John. Hello, everyone. Really nice meeting you and seeing you back again after a long time. I'm Nathalie Christelle Gomsi. I'm a general practitioner in Cameroon. As we said earlier today, as John said earlier, I will present today on the penetrating head trauma. Penetrating head trauma. Excuse me.
Okay. Oh, you lost the screen share.
No, I just wish to
It's okay.
switch my connection so that it won't go away.
That's all right.
Okay.
We have to get used to the tech. And I can edit this out. We can edit this out. There you go. Perfect.
Okay. I said earlier today I'm going to present on penetrating head trauma. In order to, my presentation will follow this plan. After a brief introduction, I'll talk a little about its epidemiology. I'll try to outline the mechanism of injury so that we can better understand what penetrating head trauma is about. I'll also outline its physiopathology, the diagnosis, its management, prognosis, and then I will conclude. Penetrating head traumas are injuries that occur when penetrating traumas are injuries that occur when the object pierces the skin and enters the tissue of the body, creating an open wound. But then penetrating head traumas, also known as penetrating brain injuries, is when there's a breach of the coverings of the brain, that's the meningitis, with high chances of damage on the neurovascular tissues. All traumatic brain injuries which are not the results of blunt mechanism is classified as penetrating brain injury. Although less prevalent than blunt head trauma, PBI carries a worse prognostic. It remains one of the most devastating lethal forms of trauma. Its prognosis is generally poor, and for those who survive long enough to make it to the hospital, the management of PBI presents complex challenges to medical and surgical providers in the civilian sector. This image is showing this a child, a 17-year-old child. This is a study which was done by Dr. Kabulo under the supervision of Professor Kalangu. A 17-year-old child deceased, which demised after a penetrating penetrating head injury by a gunshot. It represents 14% of all head traumas for Carvalho and all in 2018, and this finding was similar to that of Singe and collaborators in 2017, which was 12% of all head traumas. Approximately 70 to 90% of these victims die before arriving at the hospital, and 50% of those who survive to reach the hospital die during resuscitation attempts in the emergency department. Approximately 32 to 35,000 civilian deaths are attributed to penetrating brain injuries each year, with firearms-related injuries being the leading cause of mortality in this group. In the United States, for example, among approximately 20,000 gunshot injuries to the head, we have approximately 20,000 gunshot injuries to the head every year. Half of these gunshot injuries are due to suicides. These injuries have a higher mortality suicide has a higher mortality due to the close ranges at which the firearm is discharged. In 2010, for example, the total healthcare costs attributed to traumatic brain injury were reported by the CDC as $17.5 billion, with severe traumatic brain injury accounting for 90% of the costs. Traumatic brain injury, in order to understand better the lesions that we cause, that we have during penetrating brain injuries, we first have to have a knowledge about the ballistics, and the different energy, the energy used to create the different lesions, which are different from that of blunt trauma during penetrating head injuries. It's a result of a traumatic brain injury is a result of energy being transferred from an object to the human skull or an underlying brain. The penetrating object has a kinetic energy that is proportional to the projectile, equal to the mass times the square of its velocity. Most non-bullet penetrating objects such as nails, knives, or scissors impart less damage to the skull and brain because they have less kinetic energy to transfer on impact. So on this radiography, on this X-ray, we have it was an anecdote. It's a young guy, a gentleman who entered in the hospital in Mexico and who had a scissors, he was stabbed by a scissors into the head. He was called a gentleman with penetrating brain trauma because the guy was very nice. He was very polite when he entered. He wasn't shouting. He wasn't crying because there was a scissors in the head. He was very polite and was very calm. On the second image is that 17-year-old boy. That's the second X-ray down. Is that 17-year-old boy that we saw previously by Professor Kalango and Dr. Kabulu, who had a penetrating injury of PBI. We can see a bullet inside at the center of the head. Ballistic is the study of dynamics of the projectiles, and ballistic properties depend on the kinetic energy, its mass, its velocity, the shape, and other properties such as the weight of the person who uses the gun or the projectile. Wound ballistics is the study of the projectile acts on the tissue. The bullets tend to have less mass but travels at higher velocities, though bullet velocities can vary based on a number of factors such as the muzzle velocity, traveling through the air, the travel to the impacted target. Modern firearms projectile velocities can range from 200 meters per second in handguns to more than 1,000 meters per second in some rifles. High velocity bullets fired from rifles have the potential to do more damage than bullets fired from handguns. Though some large caliber handgun rounds are of sufficient mass to make up for their lower velocities with regard to kinetic energy. Other factors which can influence PBI include distance from which the round is fired, the yaw or tumbling that occurs when the bullet impacts the soft tissue. The bullet design causes it to deform or fragment on impact. Bullets fired from closer ranges often cause more damage than when the same bullet is fired from a longer distance. Example for those who commit suicide. Non-deforming projectiles have a tendency to yaw inside the tissue, which increases penetration and results in moderate wound cavity size, while deforming rounds have more superficial penetrations but forms larger wound cavities. On this graphic, it tries to represent the permanent and temporary wound cavities in ballistic gels. Permanent and temporary cavities in ballistic gels. This permanent cavitation is caused by the cavitation that we have on the trajectory of the projectile. While the temporary cavity, that's the image around, is the sonic waves that the projectile produces on its trajectory. There are different factors which determines the extent of injury. We have the low velocity projectiles, low kinetic energy, minimal shock waves, such as knives, that has a speed of less than 100 meters per second, and weak points of entry of the skull. As for high velocity projectiles, they have a high kinetic energy, high shock waves. Examples, we have the guns. We have the nature of the projectile, point of entry and the angle of projectile, the characteristic of the intervening tissues in the brain, in the skull, and the anatomic and neurovascular structures of the on the passage. In 1988, Facker and Alltright came out with the classification for PBIs. They classified them into 5 categories. This classification helps assist providers in surgical planning, anticipating complications, and prognosis. The first type is the tangential wounds. Here, the projectile do not penetrate through the skull. The projectile impacts the head, as you can see here, and the head at an angle, and results in a superficial damage of the scalp without wounding the parenchyma. But though it is associated with the best prognosis, tangential injuries can cause underlying injuries to the skull, meninges, and cortex, including skull fractures. In meninges and cortex, we have skull fractures, CSF leaks, epidural and subdural hematomas, or cortical contusions. The second types are carrying injuries. Here, the projectile penetrates. It is a very unusual type of injury. Here, the projectile penetrates the skull, but travels along the periphery of the cortex without wounding, without penetrating through the parenchyma. In this type of injury, we have a high risk of venous cyanosis injury, and therefore we can have subdural hematoma or intracranial hemorrhage. The third type, we have the penetrating injuries, where the projectile enters, when the projectile penetrates the skull and the brain parenchyma, and then remains inside the brain parenchyma. The fourth is the perforating injury. The perforating injuries, they are usually caused by high velocity projectiles. They are the most devastating. Here, the projectile penetrates the skull and then exits at the side distal to the entry point. It is both penetrating and perforating injuries are usually associated with other cerebral injuries such as cerebral contusions, hematomas, CSF leaks, pseudoaneurysms, and arteriovenous fistula. We shall see more later. The fifth is the ricochet injuries. In this type of injury, the projectile penetrates the skull and the brain and then ricochets on the inner table of the skull. This occurs often with low velocity projectiles and creates a new wound trapped in otherwise uninjured brain tissues. As we said before, here is an MRI which tries to illustrate the 5 categories of penetrating brain injury. We saw the perforating injuries where the projectile penetrates the brain and the parenchyma and then exits at the distal part of the opposite to the initial entry. We have the penetrating injuries where the projectile penetrates the skull and the parenchyma and then remains inside the parenchyma. We have the ricochet. We have the carrying where it penetrates the skull and then travels at the peripheries of the parenchyma without touching the parenchyma, without injuring the parenchyma. And then we have the tangential injuries. As for its physiopathology, there's immediate intracranial injury as a result of neural and vascular destruction caused by the projectile traveling through intracranial tissues. Once the projectile strikes the head and transfers its kinetic energy to extra and intracranial tissues, destruction occurs in tissue both in the projectile part, and as well as distant tissue outside the projectile part, creating the permanent and the temporary cavitation. Permanent cavitation occurs in tissue directly in the projectile part, but the sonic waves, as I said before, followed by the pressure waves of as much as 30 atmosphere produces a temporary cavitation that's around the projectile part. The expansion and retraction of the temporary cavities will cause distant punctuate hemorrhage and neuronal membrane disruption. This results in rapid rise in intracranial pressure and intracranial pressure as the hematoma enlarges and cerebral edema increases as early as 30 minutes after the initial injury. That's why patients who present PBI at the beginning usually do not have a loss of consciousness. Some can present themselves with being normal and then they deteriorate secondarily. Currently, cerebral perfusion pressures decreases. Concurrently, cerebral perfusion pressure decreases and infarction can follow if severe herniation can occur. Kajaveli and collaborators described reduced regional cerebral oxygen and consumption and concurrent global glucose uptake in animal models. They referred it to as penetrating ballistic-like brain injury model. They noted that there's the lesion core and the perilesional areas showed lesion core and perilesional areas showed similar metabolic impairment, but with less severe metabolic impairment and less neurodegeneration occurring in the later. Coupled with the knowledge that mitochondrial damage in the cavitation zone results in the release of various neuroinflammatory mediators that can cause necrosis and neuronal apoptosis in distant tissues. This information provides evidence that perilesional lesions should be amenable to acute surgical and medical therapies and yet to be identified as neuroprotectant. This was best explained by Zolo 2 weeks ago. In contrast to blunt trauma, hemorrhagic shock and cardiac arrest can occur secondary to blood loss. The scarred risk of vascular supply and hemorrhage from meningeal vessels, parenchymal vessels, and venous sinuses can result in death by exsanguination. Acute traumatic coagulopathy due to release of tissue thromboplastin from the brain can result into diffuse intravascular coagulation, which this can be seen particularly in the setting of polytrauma, but also isolated head injuries. Early identification of related bleeding complication or emergent resuscitation is an important factor in decreasing the mortalities of patients with PBI. As we said earlier, the clinical diagnosis is usually a little bit poor. The patient can present itself with a heavy bleeding from the head, which can be from the scalp, or even which can be also from the scalp. It can present with a otorrhea, which can be taken for a basal skull fracture, with repairs, respiratory distress, seizures, loss of bowel and bladder function, neurologic deficits or loss of consciousness or even coma. The utility of various neuroimaging methods used in patients with PBI lies on the potential management of prognosis implication of these modalities. Important findings include we have to know the entry and the exit sites of the projectiles. We have to know it helps see intracranial fragments, missile tract and its relationship to both vessels and air containing skull-based structures, intracranial air, transventricular basal ganglia and brainstem injuries, missile tract crossing the midline, multilobar injury and basal system effacement, brain parenchymal herniation and associated mass effects. Neuroimaging is vital for surgical decisions. It helps the neurosurgeon to see the type of surgery that could be done, the size and the site of the craniotomy or the craniectomy, the route for extraction of the foreign body, as well as the decision to choose non-surgical management, which is also not uncommon in PBI, in the management of PBI. The first type of neuroimaging proposed is plain films. It identifies the cranial wounds, locates missile and bone fragments, and the presence of intracranial air. This exam is usually used in low and middle income countries where you don't have the possibility of having CT scan. However, evaluating the projectile trajectory with plain radiographs alone can be misleading in the presence of intracranial ricocheting or fragmentation. Besides, the availability of CT scanning largely precludes the use of plain radiography, and it is not more routinely recommended, except in our low and middle income countries where we don't have a choice. The CT scan is the primary modality used in the neuroradiologic evaluation of PBI. It is quick and easier to do, and it provides improved identification in the driven bone and missile fragment. It characterizes the missile trajectory, evaluates the extent of brain injury, and detects intracranial hematoma and mass effects. All patients, it should be noted that all patients with craniocerebral gunshot injuries should be imaged immediately with an enhanced CT scan, regardless of whether or not there is an evidence of penetration on clinical examination. Postoperatively, CT scan can be helpful in evaluating the development of intracranial hematomas, the presence of residual foreign bodies, and the extent of cerebral edemas. As for the MRI, the magnetic resonance imaging is not generally recommended for the use of acute management of PBI. It is time-consuming and can potentially be dangerous when there are retained ferromagnetic objects because of the possible movement of the object in response to the magnetic torque. Though it can be used in PBI caused by wooden objects, that's if you are very sure that it's a wooden object. Cerebral angiography is used in patients who have PBI with a high risk of vascular injuries. This high risk could be seen during when doing the CT scan in this patient. It depends on the wound trajectory seen on the CT scan. For example, if the wound trajectory is through or near the Sylvian fissure, that's location of the M1, M2 segment of the middle cerebral artery, the supraclinic carotid artery, the vertebrobasilar vessels, the cavernous sinus, or the major dural venous sinuses, a cerebral angiography should be asked. Peripheral branches of the middle cerebral artery, followed by the anterior cerebral artery, are more vulnerable to PBI lesions than in the internal carotid artery. The development of unexplained subarachnoid hemorrhage or delayed hematoma could suggest vascular injury. Here we have a pseudoaneurysm of the M4 branch, the M4 segment of the middle cerebral artery, which occurred after a gunshot. As for the monitoring of intracranial pressure, the concept is based on Morrow Kelly, as Dr. Sidney rightly gave us the explanation last time. The brain volume, it says that the brain volume may increase because of edema. That's predominantly cytotoxic after trauma. Vascular volume can also increase if venous outflow is blocked, or if there is an increased cerebral blood flow because of seizures, pyrexia, or loss of autoregulation. Cerebrospinal fluid volume may also increase because of blockage of outflow tracts, or hindrance with reabsorption. An increase in the ICP is documented to be a predictor of worse prognosis. The treatment measures are just as that of blunt trauma. That's the use of hyperventilation, ventilation, the use of mannitol. We can do CFS drainage, lumbar drainage, the use of high-dose barbiturates, or more recently use decompressive craniectomy. Now let's talk about the management of PBI. The main aims of the management of PBIs are debridement and devitalized tissues, evacuation of hematomas, removal of accessible bone fragments, removal of bullet fragments, obtaining hemostasis, dural closure, and repair depressed core fractures and decompression of edema hemispheres or edematous hemispheres. The first modality we can have is surgical management. Local wound care and closure can be used for injuries where there's a small entrance of bullet wounds and there's no devitalized tissue, with no significant intracranial pathologic findings. More extensive wounds with non-variable scabs, bone, or dura should be debrided more extensively before primary closure or grafting to secure a watertight wound. When there is a significant mass effect, necrotic brain tissue should be debrided and safely accessible bone fragments should be removed. Intracranial hematoma should be evacuated. Routine surgical removal of bone and missile fragment loads distant from the entry site, especially in the eloquent areas of the brain, is not recommended. It has been documented to correlate with worse outcomes and higher morbidity. A conservative approach towards cerebral debridement in general has thus been recommended. It should be performed within 12 hours of the injury to decrease the risk of infectious complications. When the trajectory of the missile violates an open air sinus, a watertight closure of the dura should be done, as the literature suggests that it may decrease the risk of abscess formation or CSF and CSF fistulas. It is debatable that which technique amongst craniotomy or craniectomy is the best to achieve the most optimal results. No statistically significant advantage of one technique over the other has been described in reports of morbidity or mortality rates associated with the two procedures. A recent large study of military patients suffering from severe PBI reported optimum outcomes with early decompressive craniectomy. Secondly, we shall talk about the management of vascular complications. Vascular complications accounts for 5 to 40%, 50% of all PBI in various reports. Wounds with higher risk of vascular complication include orbitofacial or derional PBI, the presence of intracranial hematoma, and injuries with fragments crossing 2 or more dural compartments. The common complication we can have is traumatic intracranial aneurysm, as we saw earlier, arteriovenous fistula, subarachnoid hematomas, and vasospasm. Traumatic intracranial aneurysms accounts for approximately 20% of traumatic brain injuries. Of 20% of traumatic aneurysms after a traumatic brain injury are caused by penetrating brain injuries. Traumatic intracranial aneurysms caused by PBI are mainly false aneurysms, that's pseudoaneurysms. Once identified, surgical and endovascular repair are the treatment options. On this image, we have on this angiogram, we have the image of a pseudoaneurysm of the anterior cerebral artery, of a branch of the anterior cerebral artery just here. As for subarachnoid hemorrhages, the frequency is of 31. Its frequency in PBI accounts for 31 to 78% of PBI. It has been documented to correlate significantly with a high mortality. Additionally, Subarachnoid hemorrhage near large vascular territories or an intraventricular hemorrhage may lead to poor outcomes. Here we have the penetrating, we have a penetrating category, a penetrating category of PBI, where we have we can see the subarachnoid hemorrhage almost by this hyperdensity of the basal systems. As for vasospasm, it is a dreaded complication of subarachnoid hemorrhage, which is caused by reactive smooth muscle contraction in the walls of the vasculature. It can lead to ischemia and infarction. It can be detected by increased velocity on Doppler sound. Its treatment is include medical management or endovascular angioplasty. Its medical management includes the reduction of the blood pressure, hypervolemia, and hemodilution. Talking about CSF leak, it is a common complication of PBI, about 28% of PBI with high prediction of infectious complications. It develops because of the dural tear by the missile along with a failure to adequately seal the defect by normal tissue healing processes. The guideline for the management of penetrating brain injuries recommended the surgical correction of CSF leaks which do not close spontaneously or are refractory to CSF diversion through a ventricular or lumbar drain. The injury wounds associated with CSF leaks need to be extensively explored in order to allow watertight closure by the neurosurgeon, either by direct closure of the dural defect or by using grafting material. Though these synthetic grafting materials can, however, by virtue of being a foreign body, become a potential source of infection, and they must be used cautiously, especially in grossly contaminated wounds. There is a high risk of inhalation syndrome, so care should be taken before placing a lumbar drain. So this is an image which illustrates the placement of a lumbar drain. As for antibiotic prophylaxis, infectious complications are not uncommon in penetrating brain injuries. As for usually the object which is causing the injury is usually a foreign body. So coming with all the germs which can be found on the surface of the body or outside. And they are also associated with high morbidity and mortality rate. The risk of local wound infections, such as local wound infections, meningitis, ventriculitis, or cerebral abscess, are particularly high among PBI patients because of the presence of contaminated foreign bodies, skin, hair, and bone fragments driven into the brain tissue along the projectile tract. More frequent when cerebrospinal fluid leaks, air sinuses wounds, or transventricular injuries, or they are more frequent when the CSF leaks. They are more frequent when CSF leaks, air sinuses are wounded, or we have transventricular injuries, or those ones crossing the midline. We have wounds which crosses the midline. Staphylococcus aureus is the most frequently associated organisms. The administration of broad-spectrum antibiotic therapy is deemed necessary in this case. A study done by the British Society for Antimicrobial Therapy on infections and neurosurgery recommended the use of a double antibiotic for PBIs. We have the use of intravenous coamoxiclav, that's amoxicillin and clavulanic acid, 1 per 2 grams every 8 hours, or the use of intravenous cefuroxime, 1.5 grams, and then 750 milligrams every 8 hours, associated with intravenous metronidazole, 500 milligrams every 8 hours, or 1 gram every 12 hours, per rectum or 400 milligrams every 8 hours through the mouth. As for the use of prophylactic anti-seizure treatments, the risk of post-traumatic epilepsy after PBI is high, probably due to the direct traumatic injury to the cerebral cortex, with subsequent cerebral scarring. About 30 to 50% of patients suffering from PBI will develop seizures. It is estimated that up to 10% of them will appear early, that's the first days after the trauma, and 80 during the first 2 years, but 18% may not have their first seizures until 5 years or more years after the injury. It is recommended to administer prophylactic anticonvulsivants such as phenytoin, carbamazepine valproate, sodium valproate, or phenobarbital within the first weeks after the injury. The prognosis of PBI depends on various the prognosis of PBIs depends on various entities. We have its age. The more the patient is old, the lesser the prognosis is good. We have the suicide attempt, as we said before. In suicide attempt, the patient, the projectile is too near the skull. So usually patients which commit suicide have a less good prognostic than those being shot at distance. It depends on the mode of injury. As we said, low velocity projectiles are better than have a better prognostic than high velocity projectiles. A patient with PBI should maintain a good pressure, a good arterial pressure. As any patient presenting with hypotension, since this patient will present with usually uncontrolled bleeding or severe bleeding, this patient it should be regulated. This hypotension has to be regulated fast, so that the prognostic of the patient should be better. Patients with coagulopathy have a lower prognosis. With respiratory distress have a lower prognosis. The lower the Glasgow Coma scale, the more the prognosis is bad. Patients who have an increased intracranial pressure have a low prognosis. And if on the CT scan, we have findings such as bihemispheric lesions, multilobar injuries, intraventricular hemorrhage, ankle herniation, or subarachnoid hemorrhage, these patients usually have low prognosis. To conclude, we see that PBI is though less prevalent than blunt traumas, blunt head traumas carries a worse prognostic. The publication of guidelines for the management of penetrating brain injuries in 2001 attempted to standardize the management of PBIs. Optimal management of PBIs requires adequate comprehension of the mechanism of injury and its physiopathology. CT scan remains the exam of choice of PBIs. CSF leaks are common in PBI patients, and surgical correction is recommended for those which do not close spontaneously or are refractory to CSF diversion through ventricular and lumbar drain. The risk of post-traumatic epilepsy after PBI is high, and therefore the use of prophylactic anticonvulsivant is recommended. Advanced age, suicide attempt, associated coagulopathy, Glasgow Coma scale of 3 with bilateral fixed or dilated pupils, and high initial intracranial pressure have been correlated with worse outcomes in PBI patients. We shall not, these are our references. We shall not finish here. I'm going to present on a case study which was done by Dr. Kabulo under the supervision of Professor Kalango. As I said earlier, he was a 17-year-old boy, previously well, who was shot on his head by a friend when they were playing. The main complaint after the shot was mild headache. He had no seizures, no loss of consciousness, or any deficit of any kind. On clinical examination, the hemodynamic parameters of the child was good. That's with a BP of 110/69, pulse of 67 beats per minute, a respiratory frequency of 18 breaths per minute, a temperature of 36.1 degrees Celsius, and a SpO2 of 100% on free air, and a Glasgow Coma scale of 15/15. His pupils were at 3 millimeters bilateral, that was normal, no deficit. Biological findings were without any peculiarity. When the patient, when the child was run an X-ray, we found this bullet, image of the bullet intracranially. So he had a penetrating category of head injury. On CT scan, we had the same image. As we can see, the cavitation is very important. The cavitation through which the bullet passed is very important. This is it. It was the trajectory, and we have lesions around. We have lesions around. So on CT scan, they confirmed the bullet placement in the supratentorial space with hemorrhagic contusion in the left cerebellar hemisphere and posterior fossa pneumocephalus. The sulci and gyri were effaced and no evidence of intraventricular hemorrhage. You can see here the ventricles are really free. There's no hemorrhage. The evolution was that the child remained fully conscious and neurologically intact for 24 hours. After these 24 hours, the level of consciousness suddenly started deteriorating, associated with vomiting. And when he was trying to be run to the CT scan for another brain scan, he demised on the way. So on postmortem, a postmortem examination was found the bullet inside was in accord with the CT scan. That's the bullet was at the supratentorial level. I thank all of you for your attention.
Thank you, Nathalie, for putting that all together. Pretty large presentation overview. We're fortunate enough to have 3 neurosurgeons here. Let's get their take on what you said and anything they want to say about closed head trauma. Would you want to make some remarks, Marco Milani? Are you there, Marco?
Yes, I am. No, just want to congratulate with Natalie. It's a great presentation, very complete, that face on topics not so common, because as she just told, most part of these patients don't reach the operating room, so it's unusual. That's it.
Okay, any remarks, Dr. Gabullo? Hello, Dr. Gabullo.
Hello, Dr. Bennett. Hello, everyone. Congratulations, Dr. Nathalie. That was a great presentation. Yeah, I came a little bit late. I found you on pathophysiology. So that was great. Congratulations. So like you see in the case you presented, they affect us, like you mentioned before, they affect us which carry poor prognosis, like a bullet which is crossing the midline, a bullet which is crossing the posterior fossa, a bullet which is also crossing at the level of basal ganglia, and also a bullet which is crossing at the zona fatalis. Zona fatalis is just the zone which is a few centimeters above the cellar region. That's where the vessels forming the circle of Willis are. So that carries also a poor prognosis. Like our patient, there was a posterior fossa, because the bullet entered through the anterior ear, it went in the posterior fossa, then up, it crossed the tentorium, and it was found in the splenium of the corpus callosum. So we had all things, like 3 factors for poor prognosis. But that was a great presentation. Thank you so much.
Thank you, Dr. Cabullo. Mauricio, do you have much experience with penetrating head trauma? Go ahead. Oh, I'm sorry, Mauricio. Let me unmute you there. Okay.
Yes.
Go ahead, Mauricio.
Yeah. First of all, a great presentation, very explicative, clear, fluent. Congratulations. Actually, here in Ancona, we do not have lots of penetrating brain injury.
Okay.
We have a lot of car accident, falls, but penetrating brain injury, not so much. In our experience, the difference between the CBI and the other kind of trauma is there is, unless the very severe case that unfortunately they died, there is not so an emergency in sending the patient in the hospital. Of course, as fast as possible, okay. But beside the car accident, most of the penetrating brain injury we have, especially from knife, they came in our OR, ER working themselves. So this is, I would say, the difference. The penetrating brain injury, unless the most severe one, give you much more time to be treated.
Okay, very good. Okay.
I have one more comment, Dr. Bennett.
Go ahead, Dr. Cabullo.
Yes, I was also saying there are cases you can get an intracranial bullet and the patient survives for more years. In literature, there is a patient who survived with an intracranial bullet for 27 years, and the bullet was in the brain. And there is another one, it was like 30-something years, and it was now migrating, going down into the spinal cord, in the subarachnoid space. And it was now removed when it reached the thoracic region. So sometimes you can get patients like that, and they are surviving more years with the foreign body inside. If you check very well the literature, Natalie, you will see that patient, the bullet migrated and it was removed around the thoracic region. It was a very interesting case. And another one, the patient survived with 27 years with an intracranial bullet, and he died from something else, not from the bullet. Yeah, thank you.
And some patient already didn't know to have a bullet, because sometimes the penetrating hole is so small that patient even do not recognize just a little bit of pain, but nothing. And then you make the diagnosis even years later. I have a case.
True.
So generally speaking,
seems incredible, but could happen.
So generally speaking, if the patient's stable medically and not deteriorating neurologically, there's no great hurry to do anything, correct?
Not for the most severe case, but the percentage of patients that have not a so quick secondary injury with respect to car accident is higher in the penetrating brain injury.
Mm-hmm. Okay, very good. Any students have any comments or questions? Abdullah.
Hello, John.
Hello, Abdullah.
Yeah, good evening, Mr. John. Thank you so much. I'm very impressed with the preparation and the details with which the presenter made the points very clear, especially the pathophysiology, very impressive. A point I want to make here is we should have a distinction between a free-flying object injury and impalement injury. The pathophysiology should differ. The mechanism of injury and the danger it causes to the brain differs. Now, the second thing I want to say is that the two things that must be put in mind while managing patients like this, antibiotics and anticonvulsants. These two things, I think, should be mandatory in managing this patient. That's the point I want to clearly make in this presentation. In summary, she has done wonderfully well.
You know, I'm surprised that the convulsion rate is so high after that. So it's not, it's a preemptory step. I mean, it's convulsions are going to happen, right? With anybody
Yes.
with a penetrating wound of the head, they're going to happen in most cases. Convulsions.
So yes, yes, it will happen. That's why anticonvulsant, that is, in this instance, it is advised that somebody with penetrating either free-flying missile injury or impairment injury should have anticonvulsant in addition to antibiotics. It's mandatory.
Okay, very good.
Mm.
Okay. Ulrich, do you have any comments or questions? You look like you're already getting ready to say something.
No, I mean, we've had a great presentation and very, very detailed, and we had a lot of contributions from various neurosurgeons. Just taking the opportunity to thank everyone who's always coming. I mean, it means a lot for us to have you guys here and have all this expertise. We don't take this for granted. We know that it's not that often that you get the opportunity to have this many surgeons from all over the world commenting. So it helps a lot, and it helps everyone grow. This is not only an exercise of learning, but it's equally as a form of mentorship. So thank you so much for being around.
Yeah, I totally agree with that. And it will be available forever on YouTube, Nathalie. You'll be able to refer to this work forever. It'll be on celluloid. So we'll go on. Any more closing comments or questions? Or
Okay, Dr. Bennett.
Go ahead, Dr. Gabullo.
I just wanted to show this paper.
Okay, go ahead.
Can you see it?
Yes.
Yes, so it is called craniothoracic bullet migration over a period of 27 years.
Wow.
So this was a case report published in Mexico by Castillo. Like you can see, so it was now found in the thoracic spine after 27 years,
wow.
And it was removed. So yeah,
Incredible.
so I think I wanted just to show you that case.
Yeah, incredible experience. Well, okay, very good. So we'll go on to the next presentation. Let me just cut this for
the neurosurgeons. For this patient of 17 years with that bullet at that level in the brain, could we have saved that child? Could it be possible could it have possible? Because there are some studies who says that if you even remove, sometimes when you remove even the bullet, it can have it can cause other lesions while you're removing the bullets, which will.
Thank you, Dr.
Hello.
It depends on where you are. Depend on where you are and the facilities you have. Like we are here in Africa, it will be difficult without neuronavigation, without stereostatic facilities, because if you go blindly with your forceps, you miss your bullet. It means you are damaging more brain than the bullet did. So, but if you have other facilities like stereostatic, whatever, you can still go and remove that bullet. So it depends on where you are. Okay.
So can I come in here, please?
Go ahead.
While I was trying to make a distinction between penetrating missile injury and impairment is that in impairment, we all know that you have to leave the object there until you fully investigate before you know what to do in terms of the approach and how to remove it, because the impaled object might be tamponading a major blood vessel. We all know that. I failed to say that earlier on. Now, concerning the patient she presented earlier that eventually died, the patient presented initially, the clinical condition was very good. She said the patient was very okay. And I guess where facilities are available, the patient should be reviewed and monitored repeatedly, especially when the condition started deteriorating. Two things likely happened. It's either the patient continuously was bleeding, and the hematoma was enough to cause significant raise in intracranial pressure, and the patient decompensated and of course died. Or massive edema that followed. Whichever of the two, if the patient was monitored well, if it was hematoma, it could have been, I mean, the patient could have been rescued. If it was edema, I mean, the patient could have had decompression, just like you said in your presentation. That's my view, actually.
Very good.
If this patient had a monitoring, if you could have, I guess it's in an LMIC that it happened. But if you could have a monitor of ICP, for example, do you think the prognosis of this child would have changed? Do you think
yes. ICP and neuroimaging. Imaging is very important so that you know exactly, specifically what is causing the problem. ICP is increasing, but if it is a hematoma, you can't detect that just basically on ICP. You need image to know what is really causing the ICP. Is it just edema or some bleeding somewhere? My own take here is that the patient presenting earlier in a good condition something ought to have been done if facilities were available and the patient was monitored well. Apart from ICP monitoring, imaging follow-up as well could have led you to really what was going on, and you could have done something. Decompression could have, if it was just, and of course, I think it was edema that caused the problem, in addition to probably hemorrhage.
Okay, very good. Let's wrap this up and move on to the next presentation. Thanks everyone for coming, especially the neurosurgeons. And Nathalie, thank you very much. And stick around for the next presentation.
All right.
Okay, very good. Okay, so that's recorded, Nathalie, and it's going to be forever on YouTube, okay? Okay, and we have Sachimba here. Sachimba, hi. Are you all set, Sachimba?
Cool.
How you doing, Sachimba? Okay, you're muted there.
Yeah, he's muted.
Go ahead, Sachimba.
Okay. Good evening, Dr. John, from Zambia here.
Okay, so you're all set?
Yes, I'm set.
Okay, let's start. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach. This is Dr. John Bennett for Neurosurgical TV, televising another presentation of the Association of Future African Neurosurgeons. They have a weekly webinar. We're joined with 3 neurosurgeons today. Let's start off before we turn over to Dewin Sachimba, who's going to talk about management of traumatic brain injury at a resource-restricted center. Let's meet the guests first. Hello, Marco.
Hello, guys. My name is Marco Meloni. I'm a consultant neurosurgeon in Gravedona. Nice to meet you again.
Welcome, Marco. Dr. Kabulo.
Okay, my name is Kabulo from Democratic Republic of Congo. I'm currently final year neurosurgery resident at the University of Zimbabwe.
Okay, welcome, Dr. Kabulo. Abdullah Jamo, could you please introduce yourself? Go ahead, Abdullah. Are you there, Abdullah? He may have stepped away. Let's
yes,
go.
I'm here, please.
Okay, could you please introduce yourself?
Okay. I'm Dr. Abdullah Jimo. I'm Nigerian neurosurgeon and associate professor of neurosurgery. I'm currently in Rabat, Morocco for a fellowship training in gamma knife, stereotaxy, and functional deep brain stimulation neurosurgery.
Very good. We're going to have to get you to do some presentations.
That's right. I'll do that. I'll be glad to do that.
Okay, we'd love to have you. Okay, Zolo. Hello, Zolo. Go ahead, Zolo. Let me unmute you there. Go ahead. You there, Zolo? Perhaps not.
So Zolo has to leave. He has issues with the network and.
Oh, okay.
Yeah.
No problem. Fortune, could you please introduce yourself?
Yeah, I'm Fortuné Gankwe. I'm from Benin, but I live in Morocco. I'm a neurosurgery resident in the Assantou University Hospital of Fez. It is in the north of Morocco. Thank you.
Okay. Welcome again. Musindo.
Yes. I'm Augusto Musindo, neurosurgeon resident of Mozambique.
Oh, welcome. Very good. Welcome. Okay, Mom. There's Maurizio. We haven't introduced you this one. How you doing, Maurizio?
Yes, I'm Maurizio Iacoangeli, neurosurgeon in Ancona. I'm a full professor at the Polytechnic University of Marche, here in Italy.
Okay, welcome, Maurizio. Okay, very good. Dawin, it's all yours and welcome.
Hello, everyone. I'm Dawin Chimba, fourth-year medical student from Copperbelt University, Zambia. I'm happy to be here to present even this case. So I'll be presenting on management at a resource-restricted center in Zambia. So let me just try to share my slide.
Who is that? Dwayne, let me, hold on, I may have muted. No, Dwayne, your sound, are you okay, Dwayne, there?
No, he's
Yes,
having
I'm
a
okay.
connection.
I think it's a network issue.
Okay.
So
Okay.
Let me get in touch with you.
Yeah, we'll just hang here. We can always edit this out, no problem. Okay, usually he comes back on. We'll just be patient.
Okay, I want to, can Dr. Sydney? Hello?
Yes, we can hear you, Dwayne.
Okay, I think I'm having some network challenge. I'd ask Dr. Sydney to just help me share the slide.
Oh, okay. So
yeah, it's a good idea. We forgot to do that. I should have done it.
Yes, I'll get that up to John. You need
no
so
problem.
that
we can edit all this out. We'll just edit all this out. That's all.
That we can cut your video feed since the connection is not great, so that we can have you all the way.
Okay, so I cut, then rejoin.
Yeah, we just need your audio essentially, and we'll do the presenting of the slides. Okay. Yeah. So cut your video off.
No, he didn't understand. Okay, that's good. Okay, good.
Okay.
Yeah,
we just need your audio. That's all.
Let me get
sure.
Okay, well, we're learning how to do this, just like we learn how to manage traumatic brain injury. We're learning how to manage a presentation.
That's very true.
So, are you sending Ulrich the slides or me the slides, whatever?
Yeah, I'm just going to share them. Just a minute, please. It should be any moment now. Okay, let me share this now.
Okay, Dwayne, you just comment on the slides, okay? Or just introduce yourself first, Dwayne, please.
All right, so I'm Darwin Chimba, fourth-year medical student from the Copperbelt University, Zambia. So I'll be presenting on management of traumatic brain injury in a resource-restricted center. So it's a case report. So however, even though it's a case report, I'll first try to give a brief background about Zambia. And then I'll go into
bottom here, there's an option to make it bigger. Yeah, there we go.
Okay. So, so my outline, just the previous slide, please. Okay. So my outline of the presentation, we have the background, just something about Zambia. Then we go into the case report itself, where we have the introduction, the case report, investigations that were done, the treatment, and follow-up. Then we have discussion and conclusion, then the references. Okay, so next slide. So basically, the reason why I want to give the background about Zambia is because the way the patient was managed probably is not the most ideal way of managing the patient according to the protocols. So there are some factors that contributed to the patient being managed the way he was managed, and that's what I want to first bring out. So Zambia is a landlocked country in the South Central Africa. So it is it attained independence on 24th October 1964, and we celebrated independence just a few days ago. So it is headed by the president. The current president is His Excellency Dr. Edgar Chagolungu, who is the 6th president from the time Zambia attained its independence. Next slide. So that's just the map showing where Zambia is located on Africa. Next slide. Okay, so that's also just the map of Africa, and then there's the flag of Zambia. Next slide, please. Okay, so administratively, Zambia is divided into 9 provinces. 10 provinces, which are subdivided into 118 districts with 72 tribes. So the capital city is Lusaka. It has Zambia as a youthful population of about 17 million, and is concentrated around the economic hubs of the country. So the population growth is estimated at about 2.93%, and the average life expectancy is about 50 years. Okay, next slide. So just briefly about economics concerning Zambia. So the main economic activities that take place in Zambia include first mining. So the major mineral that is mined in Zambia is copper, which contributes to about 70% of the export earnings. However, there are also other minerals such as cobalt, and so on. So the second economic activity that takes place is agriculture, mainly maize. Then there's also tourism, where there's wildlife, waterfalls such as the Victoria Falls, and some other historical sites. Then there's also energy and manufacturing. So those are the economic activities that take place. So with a per capita gross domestic product of around 1,700 United States dollars, Zambia is referred to be a low middle income country. So, and about 60% of Zambia's population is still lives in rural areas where they depend on subsistence agriculture for their livelihoods. Then about 60% of the total population of Zambia is below the recognized national poverty line, with much of this concentrated in rural areas. So, like I mentioned, on the economic activities that take place, where I mentioned that one of the economic activities that take place in Zambia is mining. So Zambia's economy has relied, for many years, it has relied heavily on copper, but this employs less than 2% of the population. But the Zambian government is pursuing an economic diversification program to reduce the economy's reliance on copper industry. So on healthcare, right now the government of Zambia is focusing on what is called the universal health coverage, which is a global health policy agenda that has been adopted by the government of the Republic of Zambia as one of the targets of the Sustainable Development Goals. That is number 3, which is to ensure health lives and promote well-being for all at all ages. So there's so much focus by the government on the provision of a continuum of care, with particular emphasis on promotion, preventive, promotional, preventive, curative, and rehabilitation services. The provision of a continuum of care is challenged by the burden of diseases in Zambia, which is very high and characterized by high prevalence of communicable diseases and emerging burden of non-communicable diseases. So basically, in Zambia, there are quite a number of communicable diseases as well as non-communicable diseases. So the government of Zambia is trying to reduce on those communicable as well as non-communicable diseases. So this has had a very significant impact on the morbidity and mortality levels across the country. So in just something about key determinants of health. So in Zambia, the health of individuals and communities is to a large extent determined by the environments and circumstances in which in which they live and operate. So these include the social and economic environment, the physical environment, and the person's individual characteristics, behavior, and circumstances. So if we look at the WHO definition, behavior, all those they come into play in determining someone's health. So even in Zambia, those are some of the determinants of health. Next slide. Next slide.
He's saying next slide.
Next slide. It's just a picture showing some of those determinants of health, like I mentioned. You can go to the next slide. Okay, so in Zambia, in the Zambian context, the general challenges to health for all are as follows. So one, the issues of poverty. Okay, so like I mentioned earlier, that about 60% of the entire population is still living under the standard poverty line. So most of these are concentrated in the rural areas. So you find that people, they're not able to these healthcare services. Then other than that, there's also 22 tribes, of which of those they have different social and cultural considerations. So because of that, you discover that patients probably respond differently. Rather, it's not always that someone will go to a health facility. Others will resort to traditional medicines and things like that. Then access to safe water and sanitation. So if there's no safe water and sanitation, we find that there are a lot of people that will be presenting probably with waterborne diseases, foodborne diseases, and so on. Then there's also a burden of malnutrition, education aspects, and occupational health. You can go to the next slide. Okay, so health services in Zambia are delivered in a services delivery structure, aiming at providing health services as close to the family as possible and with a primary health care approach. So to achieve this, the services delivery system was designed with the following structure. Next slide. So first of all, we have people, rather patients can be treated at community level, where basically sometimes we have what we call community health assistants who are there to attend to patients. Then from there we have health posts, we have health centers, then we have first level hospital, second level hospital, and third level hospital. So that is basically the structure of healthcare delivery. We can go to the next slide. Okay, so each of these levels of healthcare delivery faces enormous challenges, which include infrastructure. So infrastructure at different levels of healthcare delivery has remained a challenge. So right now, the government of Zambia is actually trying to build more healthcare centers, more hospitals, including specialized hospitals. So, but in the recent past, it has been a challenge where, especially in rural areas where most patients are not able to access healthcare services. But right now, there's quite some impressive works that are going on, trying to make sure that people are able to access healthcare services. Next slide. Okay, then next we have medical imaging and laboratory services. So we find that especially when it comes to, I think even the previous presentation, it was mentioned that when it comes to diagnostic techniques, especially imaging, it is quite a big challenge. However, we find that in most centers there are no CT scans and other proper investigative techniques. Then the other challenges on human resource. By the way, these are just some of the challenges that I tried to pick out. Human resource. So currently, the doctor-patient ratio stands at about 1 to about 15,000 patients. So like I mentioned, in Zambia, the population is about 17 million. So out of that, about one doctor is going to handle about close to about 15,000 patients, which is quite low compared to the recommended WHO standard. Then the government of Zambia, through the Ministry of Health and Ministry of Education, has embarked on training doctors and specialists to meet the WHO recommended doctor population ratio. Next slide. Okay, so on health insurance, Zambia has in a long time not had any health insurance scheme. However, after a lengthy consultative process, which began in the year 2012, and after various studies were taken, the National Health Insurance Bill was finally assented to and is now a law in Zambia. Next slide. So the law is known as National Health Insurance Act 2 of 2018. So the National Health Insurance Scheme is or will be based on the guiding principles of universality, social solidarity, equity, affordability, and efficiency, as well as effectiveness and accountability. So this National Health Insurance Scheme is aimed at covering all Zambians, despite their race, despite their economic status, despite their religion, religious affiliations or political affiliations. So it is basically or aimed at meeting all sectors. So you can go to the next. Okay, so now I want to go into the case report itself, which is management of trauma restricted center. So it is challenge, and it contributes significantly to mortality and morbidity in a good number of trauma patients. Okay. Then some of the causes, you can go to the previous slide, please. Okay. So some of the causes of traumatic brain injury include falls, road traffic accidents, and violence, as well as occupational accidents. Then traumatic brain injury is a public health concern, like I mentioned, and worldwide, and is still being managed by general surgeons in most low and middle income countries, including Zambia. So surgery is one of the neglected areas of health care cover delivery. And in order to achieve, like especially in Zambia, to achieve this, the universal health coverage, there is need to incorporate surgery in the primary health care. Now, in low middle income countries, the access to emergency and essential surgical care, as well as anesthesia, is quite a challenge, and that's why management of this traumatic brain injury still remains a challenge in such settings. You can go to the next slide. Okay, so this is a case of a 42-year-old man who presented with a 11 days history of headache, aphasia, right-sided hemiparesis, which started 2 days post interpersonal violence. So he presented to the facility with a GCS of 11 out of 15. Systemic examination was there were no abnormalities that were detected. The patient was hemodynamically stable. So like I mentioned, this patient presented to the hospital, rather to our facility, 11 days after the incident had happened, after he was involved in an interpersonal violence. And then he only developed the symptoms 2 days later. So this was some case that was quite surprising, because we couldn't initially think of epidural presentation, like things to do with the lucid interval and so on. But the patient developed those symptoms, like there was no loss of consciousness, there were no convulsions that were there. He only presented to the he only developed those symptoms 2 days after the trauma to the head. So the main complaints were headache, like I've mentioned, aphasia, right-sided hemiparesis, and so on. You can go to the next slide. So on the investigations that were done, first we did a full blood count, which was normal. The kidney function tests were normal. Then on imaging, now I must mention that this patient were only able to take this patient for MRI that was about 22 days after the incident had happened. Now, what actually happened was when the patient came to the facility, CT scan was ordered. Unfortunately, the hospital CT scan was not working at that time, so we had to rely on a private hospital for CT scan or MRI. But that made the expense, rather the cost of the patient having that MRI done quite high. So the patient managed to get enough funds to go for the MRI about 22 days after the trauma, which was about 12 days after the patient presented to the facility. So the MRI showed occipital epidural hematoma, cerebral edema, but there were no basal skull fractures. You can go to the next slide. Next slide, please. Okay, so what was done for the patient? Initially, when the patient came to the facility, there was initial assessment and management. Like I mentioned, this patient came, he was hemodynamically stable, and there were no emergent signs in this patient. So the patient was put on IV fluids, basically maintenance fluids, then was prophylactically covered on antibiotics, because he stayed in the hospital for quite long. Not really because of the traumatic brain injury, but because of the fact that he stayed in the hospital for quite some time. Then on day 11 post-admission, after the patient was admitted, the patient was taken to theater for craniectomy. Then after craniectomy was done and drainage was of the hematoma was done, a drain was left on the site of the craniectomy. Next slide. Next slide. Next slide.
Do you want to move past this?
Okay. So post-operation. Sorry.
Go ahead.
Sorry.
Go ahead.
Okay. So post-operatively, the patient was taken to the intensive care unit. Then on day 1 post-craniectomy, the power on the right upper limb and on the right lower limb became 1 out of 5 from the initial, which was 0 out of 5. Then by day 2, it was 5 out of 5. Then further series of reviews showed that the patient was improving and the patient recovered fully. Next slide. Okay. So on my discussion, just basically about traumatic brain injury, I think it was covered by Zolo a few weeks ago. So traumatic brain injury can be clinically graded depending on the GCS, as that is the severity score, as mild, moderate, or severe. Then it can also be classified as primary or secondary. Then when you look at the Monroe-Kelly hypothesis, where we look at the fact that the cranium is a fixed space containing of the brain tissue, blood, and the CSF. So if there's increase in any of these, there's going to be a compensatory decrease in the other two. So if we have, when you look at cerebral perfusion pressure, it is a factor of mean arterial pressure and intracranial pressure. So when there's increase in intracranial pressure as a result of increase in the 3 components of the cranium, then there's going to be a decrease in cerebral perfusion pressure. Then this will ultimately compromise the metabolism, the cerebral metabolism, due to hypoxia. Then there's also need to maintain cerebral perfusion pressure as well as oxygenation. Next slide. So on my conclusion, so like I've mentioned, this was a case that was done at a resource restricted center, and like we have seen from how the patient was managed, it is not the ideal way, or rather according to the protocols of managing such a case. Okay, because the patient was ideally supposed to be taken for craniectomy probably on the same day when the patient came, but because of the challenges that were there, the patient was taken to theater day 11 post-admission. So there's need for basic neurological procedure, or rather basic neurological procedures can play a life-saving role in patients with traumatic brain injury. Then this is supposed to actually be done timely and in a safe manner, unlike what was done. Then it is important to ensure that surgical training actually is in these settings, like some neurological procedures is done. Then it is important to ensure provision of good surgical instruments and easy accessibility to advanced diagnostic techniques, which may be lacking in some of the low middle income countries. So, like I mentioned, that Zambia is referred or graded as a middle income country. So we find that some of the surgical instruments, or there's not so much availability of certain diagnostic techniques, so that these patients are managed in a timely and safe manner. Okay. Next slide. Okay, so those are my references. Thank you very much.
Okay, excellent, Wente. Thank you for putting all this together. And I'd like to just basically ask the neurosurgeons, have they ever been in a hospital where you really didn't have, you only had the basic equipment? Marco, have you ever worked in a hospital like that?
John,
Yeah.
can we, before we start with the questions, can we first of all give some feedback to Darwin, please, because he's a medical student who is really interested. He wants to be a neurosurgeon, and there are a few things which I think will be helpful if you can get us feedback. And I noticed that there are a few things.
One of the things that I think he needs to hear is the experience of these neurosurgeons. So we're going to go ahead and do that. Marco, have you ever been at a challenged hospital, or you didn't have the equipment to use?
Well, in
basic stuff.
Well, in my hospital, we fortunately we are quite trained and prepared in neurosurgery. So for emergency like a trauma, we have a good neurosurgery, a good intensive care unit. The only problem is about brain aneurysm, in particular posterior circulation, because we don't have an endovascular unit. So the only problem in a hospital is when you have an aneurysm, like a basilar tip, you need to move the patients in an endovascular unit that is in another hospital. So in this, for this aspect, this is a problem, but for the rest, like spine, head trauma, and other pathology, we are well equipped, and our instruments are good enough to perform this surgery to guarantee this service.
How about you, Mauricio? Have you ever been in a place where you're resource challenged?
No, not anymore. I have a question to the colleague. How many neurosurgeons are in Zambia? How many neurosurgical centers are in Zambia? And how many neurosurgeons are in Zambia for 17 million people?
Okay, currently I think there are only less than 5 neurosurgeons, and there's only one center, which is the biggest hospital in Zambia, the University Teaching Hospital in the capital city of Zambia.
So, in my opinion, beside the instrument, you almost for trauma, for such kind of pathology, I think you have enough. Of course, you have to improve, but I think there is enough technology to deal with this kind of patient. For me, the main question is the distance, the long distance, the transportation to the center. This could be an issue.
Okay. Any more comments or questions? Go ahead.
Okay, so that is also another aspect of this case, because where the patient was and the center, there's quite some distance. And like I mentioned, the patient did not present to the center, or rather to the facility, almost immediately. So there's quite a distance to the center where the patient was managed.
Okay, very good.
Dr. Bennett?
Okay. Yeah, go ahead, Dr. Kubal.
Okay, thank you so much, Darwin, for your case presentation. It was okay, well done. I will give you a few comments, then you are a medical student. We are here to help you. We are also students. We are being helped by our senior. So I will go through things which are very basic. I will end with those ones. But in terms of, I will go backward. So in terms of your prognosis about your patient, since the patient presented with aphasia and hemiparesis, you should tell us about that prognosis, how he improved in terms of aphasia and hemiparesis. And it was after how long, okay? Then usually when you are presenting cases like that, please include pictures. The time you did your craniotomy, you take pictures in theater, you include, you tell us, we see how you do it, okay? That's also good.
Okay.
Then you said the CT scan was done, it was 22 days, the MRI scan, sorry, 22 days after admission, isn't it?
No, after the trauma.
incident. Did
After
you
the
operate
incident.
the patient the same day after the MRI scan?
The patient was operated the day after the MRI scan.
The day after, it's okay. Then, like you were saying, IV fluids. Which IV fluid did you give to that patient? You know,
So the patient was
limited. You have to tell us details so we can see how to help you. Okay, which type of fluid did you give and how often were you giving?
So the patient was given normal saline, which was 2,500 meals in 24 hours.
24 hours. It's okay. Another thing on your MRI, there was a very important finding which you didn't mention. There was midline shift.
Yes.
That's a very, very yes. Then, okay, talking about basal skull fracture on MRI, it's not easy to see basal skull fracture. Bones are not good on MRI. It's better to do CT scan, thin slice CT scan. So you can't talk about basal skull fracture on MRI. Yeah.
Okay.
Then now I'm coming to the interesting part of this talk, especially you as a medical student. Your history. You gave us 2 lines of history. I like history too much because for me, when I'm taking my history, after my history, I have already an idea about what is going on. Just after taking history. Can you tell us more about the history? Then I'll give you the summary, how to take history in a head injury patient. Can you tell us more about the history of that patient?
Okay, so the presenting complaints in this patient were inability to move the right lower limb and the right upper limb for 11 days. Then there was also inability to talk. So the patient was well until 13 days prior presentation. Okay, when he was involved in an interpersonal violence after knocking off from work. So the wife reported that the patient could not characterize the objects that were used in the incidents, but reported that they tried, the people that were involved, they tried to strangle the patient. So the patient was hit on the back of the head. There was no bleeding, but there was a swelling on the side where he was hit. There was also no associated bleeding from the ears and the nose or any discharge. So the wife reported that on the day the patient was involved in the interpersonal violence, the patient was able to talk and was able to move the right leg as well as the arm, but there was associated general body pains and headache. Then 2 days after the incidents, the patient woke up with the complaints that we've mentioned, that is inability to talk and inability to move the right leg as well as the right arm. Then the patient was taken to a local general hospital where I was later referred to our facility, where he only managed to come 11 days later. So the patient only opened bowels on the day he was involved in the interpersonal violence, but he had been able to pass urine normally with no abnormal color or discharge or any pain. So the patient had been feeding well. There was no vomiting. There was one incidence of vomiting However, there was no history of convulsions, no hearing loss, no loss of taste for food or any vision disturbances. So like I mentioned, there was nothing much on the systemic review. The respiratory system, there were no any deformities that were detected. The cardiovascular system, there was no any deformities. Then the past medical history was this patient had has no relevant medical past medical history. So maybe just if I can give the summary of the history. So that is basically the history of the patient. I don't know if I can go into the examination as well.
Okay. Let's go in details about that history. Yeah.
Okay.
You know, fourth year, next year, your final year, you'll be writing, you'll be doing your long case, your short case, you'll be presenting a case on your exams. So
yes.
You said there was nothing, like the past history was unremarkable. There are things like we have to know
Past
the
medical
important
history.
negatives. Yes, there are important negatives we need to know, like in this particular patient. So let us go back to the history. The patient was assaulted. Okay. What time of the day? Where was he coming from? Or was it along the road? Was he coming from from work going back home?
So the patient was.
Go ahead, Dwayne.
Okay, so the patient was coming back from work. He was coming back from work around 19 hours, and then he was assaulted by unknown people who hit him on the back of the head with an unknown object.
How many times?
It was just once.
Once.
One time.
So immediately, did he lose consciousness? Soon after that.
Okay, so I think I mentioned there was no history of loss of consciousness. The patient only developed those 2 days after the incidents happened. So on the actual day, the only complaint that was there, he was just having some generalized body pains and headache, but there was no loss of consciousness or any other complaints.
It's okay. So generally, that's okay. That's detailed history about that patient. So generally, we tend to divide those patients into motor vehicle accident, then into fall or assault. Then in motor vehicle accident, there are also 3 subcategories. Was the patient a passenger or the patient was a driver? That's the second one. The third one, if the patient was a pedestrian hit by a car.
Okay.
So, if the patient was a passenger in a car, we want to know where the patient was seated. Was he in the front seat, back seat? Was the patient restrained or not? Okay.
Okay.
Then if the patient lost consciousness immediately after the accident. If the patient was a driver, what happened? You look also for signs, the speed on which the patient was driving, how many fatalities. If there were 5, there were 2 who died on spot, because we want to know the severity of that injury. That's why we want to know the fatalities, how many fatalities. Okay. Then also the patient who was driving, what happened? The speed on which the patient was driving, because we had the patient patient who had the stroke while driving. You know, you are driving at 30 kilometers per hour, then you had the stroke, or you start to fit, you have seizures while you are driving, then you hit an object. Not because it was an accident, but because it was something wrong on you. Then they bring that patient. People who are going to bring the patient, they will say he was involved in an accident. But if you take carefully your history, you differentiate that patient from like a seizure or a stroke, or it was a real accident. Then we want also, if the patient was hit by a car, it was a pedestrian, we want to know, was he crossing the road? Which side of the body was he hit? How he landed? Did he bleed? Did he fit? We want to know issue of seizures on the spot. If he didn't fit, like you mentioned on your patient, there was no seizures. That's a very important negative thing on the history. Then we have to know now, if it's motor vehicle accident, we want to know the mechanism of injury. What happened to the car? Was it a head-on collision? The patient lost control and veered off the road, or he failed to negotiate a cave, or he was overtaking another car, then collided with a car coming from opposite direction, or it was a burst tire, then the car overturned. So that's the mechanism of injury. It's also very important when we are taking the history. Then it's a fall. It's a fall. Okay, fall from a height. We want to know how many meters. If you don't know the meters from a building, you ask which floor was that. Then you can estimate. If it's a first floor, usually it's around 3 meters. Second floor, it's around about 6 meters. Then you know. If it was from a tree and you don't know how many meters, you can ask which type of tree the patient was. It can also help you to estimate. If it's an orange tree, you know that it's about 3 meters and so on. So with that history, if it was an assault, like your patient, what time was that assault? Where was the patient coming from? And they used what? You mentioned it, that it was a unknown object. How many times the patient was hit on the head, and by how many assailants? So those things, with those details, you have an idea about what is happening. So I was just going a bit fast and giving more important things when you are taking the history of those patients. Normally, like what I use, if I don't know, because the period of loss of consciousness soon after the incident, it is affecting the outcome. It is affecting the outcome. So we want to know for how long. If there is issue of loss of consciousness, we want to know for how long the patient lost consciousness. But now, sometimes our patients are coming, they were brought in by well-wishers, was involved in an accident, or was found lying on the road without eyewitness. If the patient is now conscious, you can talk to the patient, but don't ask how many minutes, how many hours did you lose consciousness, because he won't know. But you can ask questions like, when you regained consciousness, what did you see? Where were you? It can help you. That patient can help you to get a rough idea about how long the loss of consciousness was. If the patient says, I was still at the scene of the accident, I could see the car where I was, I could see people around me, the ambulance, when it came, I was there, then you think, this is like less than 30 minutes. No, I was already in the ambulance going to the hospital. We are in Africa. Sometimes ambulances are coming a bit late. This is maybe close to an hour. No, I was already at the hospital. Then you think like this is maybe already after an hour. So I think that a summary for you, just how to take history. And also when you are going in past medical history, for your patient, the patient is 45, male.
42.
Even if the past history is not as remarkable, we want to know, for example, does he smoke? Does he drink alcohol? Because patients like that, the moment you are admitting them, they won't smoke in the ward, they won't drink alcohol. They might develop withdrawal syndrome in the hospital, which you can miss easily and lose the patient. So that's my summary for you. Thank you.
Maybe just a comment.
Go ahead.
Thank you very much, Dr. Kabulo, for those comments. Quite something that's very important. However, I think I must mention as well that I tried to just make some sort of a summary for this particular presentation. Otherwise, on the actual day when I was taking the history and examining, I think although taken into consideration.
Oh, okay, that's great. So you should present everything. Since you're a medical student, when you are coming, just present, just bring the all clacking. Then we go through, we see how we can help you, where you can improve, and so on. So it was better to present everything. Maybe next time if you get a case, just present everything.
Okay, I will do just that.
It's okay.
Ulrich, you have anything to say?
Just one more thing. So that Darren, for the next time you're available, can you present on craniotomies and craniectomies?
Okay, I can do that.
Just prepare the presentation. When you're ready, you let me know, and then we can schedule you.
Yeah, and Ulrich, I think a panelist said he wanted. Panelist said he wanted to present. Abdullah Shamo. I don't know. Abdullah, he's doing.
Yeah, I know him very well. We're speaking. We're in touch, and he said he will try and have a presentation on stereotaxic. We're already in touch. When he has time,
okay, great. Okay, everyone, thank you very much, and we'll have this edited, and then we'll send it to everyone. So thanks everybody for coming.
Thank you. Bye-bye.
Thank you very much.
Yeah, thanks.
Bye.
Mauricio.
Bye.
Are you in an area where the food is really good?
Yes. Yes.
Is there any part of Italy the food is not good?
It depends on. It's a question of people, but we have some new entry in delicious that you can try next time you come in Italy.
Oh man,
there is something new, a mix of something new.
Yeah, I think
from Ancona.
Oh, okay. Yeah, I would come back very fat, I think.
In good health.
In good health, okay.
In good spirit.
Okay, very good.
Bye.
Bye.
Ciao.
Hey, Dr. Gabula, how you doing?
I'm fine, Dr. Bennett, and you?
Everything going good?
Yes, just the pressure. You know, it's almost 2 weeks from the exams.
Oh, wow. Your oral exams or written?
Yes.
Or both? Yeah, both together, oral and written?
Sorry?
Are they oral and written? Or
yes, the written, oral exam, clinical exam, and dissertation, to defend dissertation.
It takes a couple of days, right?
Yeah, almost 2 weeks. The first week we have 3 written papers. The first week, then the second week oral exam and clinical exam, long and short cases. Then you defend your dissertation lastly.
Wow, I didn't realize it was 2 weeks. I thought it was 2 days.
Yeah.
You'll be fine, Dr. Tabulo. You'll be fine. We all know that you'll be fine. This is a formality.
Thank you so much.
Wow. Well, you need a vacation after that exam.
Yeah, sure.
Another 2 weeks for vacation.
You have the Cameroonian jersey on, Dr. Tabulo.
Sorry?
You have the Cameroonian jersey on you.
Yes, my favorite team in Africa.
That's good. Okay, very good.
Okay, guys. Bye. Bye.
Okay, bye-bye.
Okay, thank you.
Bye-bye.
Thanks, everybody.
Bye,
all right, okay.
Well, I'm just gonna stick here, and you can stick it. Hey, in Morocco, I guess you're talking to Ulrich. You're talking to Ulrich about presenting.
Yes, that's right.
Okay, so you're in contact. So
yes,
you guys will figure it out.
All right. Okay. Yes.
And thanks, Natalie. Yeah, we'll cut out the rough parts.
Yeah, John, I remember that you threatened to punish me if I don't come back. So
oh, that's right. I get a punish. That's right. So I never heard from your mother.
Yeah, she said the same thing. She threatened to punish, so I just had to come back.
No, but she has to write me a personal note of her favorite punishment.
I'll be back. Just that things I need to. As I told you, I have some activities during the weekends, and usually I don't have a choice. I'll promise to make everything to be there. Everything.
Oh, okay. So you go out in the villages, right? To treat everything, probably, right?
And not really everything, but we try to treat the main diseases that we have in villages, in 5 villages, and we do it for free. So, and my boss is the head of the NGO, so I have to follow him sometimes.
Oh, okay. Wow.
Yeah, that's why I have to go.
Malaria is very common.
Yeah,
right?
It's very common. Very
like you see it like in a typical day how many patients would you see in a typical day?
In a
30,
typical
30?
in a typical day for malaria, but in a typical day, usually we can receive something like 1,000 to 2,000 patients.
Wow.
I think once we received even 3,000, we went to the north. The north of Cameroon is very, how can I say, Cameroon is grossly divided into the big north and the big south. So the big north is very poor.
Right.
So usually people that are very poor and they don't like hospitals. They don't even have ones.
Right.
So we go and just try to relieve and bring some smile, and then after that we're okay.
You got a lot of equipment. They give you a lot of drugs and a lot of stuff to give out.
Yeah, we
So
buy
there's
them.
no shortage of medication, right?
Sometimes we can we can be short of medication when there are too many than what we reserve for them, because we travel through with a bus and the distance is quite long. Sometimes to go to the north, I remember we made 2 days, 48 hours to arrive there, and we can't carry much. So when there are so many, we have to leave some without.
Yeah.
We don't have a choice.
Yeah, but it must be interesting though. Wow. And you haven't decided if you're going to go into surgery, you're going to stay in general practice? Or you don't know?
My boss is a surgeon. We do some surgeries like hernias, inguinal hernias. And since the patient is not, it's minimally invasive, so we can do this kind of surgeries. We can do lipomectomies. We do minimal cystectomies, minimal surgeries. We don't do large surgeries when we go in those places.
But you mentioned you might go with IPE to Nepal to see what neurosurgery is like.
I'll go there. I'm waiting for some answers. Dr. Kaburu knows I'm waiting for some answers, and then I'll schedule to go there for sure before I start my residency program.
I think that's a wise thing to do, because you'll get to see, you get to really be close to it, with IPE. He'll expose you to a lot. I was there for 3 months and I enjoyed it, and he really takes care of everybody, and it's a very nice functional unit he has there of neurosurgery. So you'll get a good idea of what's going on. Maybe you like it, maybe you won't. Who knows? Who knows?
I'll send him a mail to see if I can come, and then I'll see all the modalities, and then I'll do it before I start my residency program.
Yeah, okay. Very good. Very good. Okay. Okay, Marco. Morgan Fortune. Fortune's quiet. Hello, Fortune. Are you there?
Yeah, yes. Sorry.
How you doing?
I'm fine.
Okay, I didn't see a picture there. And Igor Nishu. Igor, can you hear me okay? Igor?
Yes, I'm hearing you.
Hi, Igor. You're in Cameroon, right?
Yes, I'm from Cameroon, but I'm a neurosurgeon resident at Ivory Coast.
Oh, welcome. And if I'm going to edit the video, I think you came to the second one, right?
Thank you, sir.
Yeah, I'm going to send a copy of the videos to everybody.
Thank you.
And Mauricio, we have your email, right?
Yes.
Okay.
Yes.
So you do get all our correspondence.
Yes.
Good.
I'll send you my university email, so you have 2 options.
Yeah, you'll be getting announcements of everyone we have, and you're certainly welcome to join any of them.
Sorry. Sorry.
Go ahead.
Yes. Please, can I get your email, because I think that I have a presentation at the 9 November.
Yeah, sure. Here, let me give it in the chat box here.
Okay.
Okay, Okay, while I'm getting it, John, I just wanted to use this opportunity to say thanks to Dr. Marco, Dr. Caburo, Professor Mauricio, and Dr. Gangpe and Nietzsche, Dr. Nietzsche, for really supporting us, FN. You know, it's true that we are co-founders with Rick, where the ancestors we started it usually is because we found that in Cameroon there was not an open vision of neurosurgery. So we are very happy that we have this great
Oh, a little audio problem.
Supporting us and being behind us. Friend, also thank you, and thank you again for Dr. Jimo. I contacted him, I think once. I don't know if you remember, but we talked once. I think he's from Nigeria, not Nigeria. I thank all of you, and not forgetting you, John. You're really giving us an opportunity to express ourselves and to make African youths. Like you have seen, Darwin is there, Zolo is there. There are many of them who are willing to come in Cameroon particularly, but most of them speak French. So they are afraid of the English. And I'm just like using my example to say, please, you can come, even though we are speaking French. There's Dr. Gampe who is speaking French, Dr. Kaburo is from...
Well, you know, if you want to do them if you want to do some in French, you can do it.
No, it's not a good idea. We thought about that, but it's not a good idea because English passes best the message everywhere than French.
Okay.
So we have to use, how can I say, we have to promote the English, that they should speak English than French.
Okay, whatever is comfortable for you guys.
They can always come. Even me, I'm a French speaker. I only started English when I started this program, my master's. So that's why my English is broken, though we are communicating. You see, the problem is to pass the message. They can still come and present like that. We are all French speakers.
Yeah. Students are welcome to come. Just don't say anything. Just watch. Just like a lecture in the university. I remember when I was a student, I was afraid to ask questions, and that's okay. It's okay to just go to the lecture and watch it, and you say, "Hey, I'm John Bennett. Thank you." That's it. Just come and watch.
We will try to invite them and encourage them more. You see, even those from RDC, there are many of them. We even met when we went to Rwanda, to Kigali, but the English, they are running away from English. We'll try to, how can I say, encourage them the best we can.
Yeah,
Dr. Mario,
don't feel bad if it's not perfect English. It doesn't have to be. We all understand that. You know, but I've seen neurosurgeons in China, from Russia, from Dominican Republic, you know, Latin Americans and Russia. Wow, neurosurgeons learning another language. It's incredible, learning to do neurosurgery in a language that's not your native language, like in places like Russia and China.
Dr. Marco, you wanted to say something.
Go ahead, Marco.
Dr. Marco.
No, I just want to express my opinion. I think if some colleagues or young students want to do a presentation in French language, is good, but I consider that you risk to have less public, because not all people know French language, and in particular, most terms in neurosurgery are in English language, because the most part of textbook of neurosurgery, like Yazarki, Roton, are in English language, so they are so all the topics in neurosurgery are best expressed in English language. That's it. So my suggestion is to if you want to do some French presentation, it's okay, but just encourage how can I say, talk with your students, with your colleagues, and tell him to participate to this panel in English. At the first, probably they won't understand a lot because they are the first at the beginning with English, but more and more panel, more and more try to talk in, nobody give them the score in English language, I think so. So try and they improve the knowledge of neurosurgery and English language too.
Well, you know, Maurice, I want to give you my my experience because I was thinking of, because I've done them in Arabic, I've done them in Russian and Chinese, Spanish, and I had a, because I went to medical school in Mexico, I learned Spanish, and I had a feeling that the neurosurgeons in Latin America would welcome a in Spanish, and I thought, let me try it to see if they like it, and they like it. Not all of them like it, but there's a significant part of this Spanish neurosurgery group that prefers in Spanish, and they liked it. So I did it. I was surprised. I've tried to do it in other languages, but most of the other people say, well, you know, it's really English. That is the language, and we prefer in English. The Spanish community I've only seen is the only one I've seen it work pretty good. So, yeah, whatever people want, whatever they prefer it in. And if they want to prefer it in English, that's fine. We'll do English, whatever. But of course, in Africa, we do English because it seems to be the prevailing opinion. Any ideas on that, Fortune?
No, it's okay. Thank you very much.
Okay. Abdullah, okay, everybody. We're gonna hit the pike, and Marco, I really appreciate, like Nathalie says, these guys don't realize how lucky they have, lucky to be in the same room as a neurosurgeon. As a student, it's gold. It's gold. So thank you very much, and thank you, Dr. Cabullo. Thank you very much.
Thank you.
Thank you so much, Dr. Bennett.
Okay, Maurizio, thank you. We'll put a poster copy. Okay. Bye bye, everybody.
Bye.